Sir, it is, I think already.
Yeah, we can start the meeting. Okay.
Yeah, we can start. We can start. Okay, I think we are all set now. So let me welcome all of you to this 276th edition of Thursday Musings. Today we'll be talking about rating scales in our field, pros and cons, and discuss about them from a very erudite, very learned speaker who will be introduced later on. Now the meeting is being recorded. The recording will be available on the YouTube for later viewing. The questions are invited in the chat box. So you have to type your questions, put in the chat box, which will be taken up to the speaker. Uh, Otherwise, everyone will be on the mute mode from uh, whole of the event. Next slide, please. I'm handing over the session to Professor Dr. Tufan Pati, sir. He is the chairman of this program. Sir, over to you. I'm not reading your slides.
No, thank you. Thank you very much, Dr. Lim, and welcome everyone to this vibrant session of Thursday Musings. Next slide, please. I take this pleasure to appreciate the vibrant moderators without elaborating their biodata. Dr. Alim Siddiqui, Dr. Amrit Patidosi, he is not there, maybe he will be joining soon. Dr. Vishal Chabra, please move on the slides. Yes. Next, and Dr. Shobit Garg, next please. So we have got chairpersons, Dr. Prerana Kukreti is Professor of Psychiatry in charge of Women Mental Health Clinic in Lady Harris Medical College, Delhi. Her areas of interest include perinatal psychiatry, forensic psychiatry, neuropsychiatry, human rights, and community psychiatry. He is author of the book Forensic Psychiatry, Indian Perspective, editor of the book Women's Reproductive Mental Health in South Asia, and recipient of Dr. G. Shivaral and Dr. A.K. Kala Awards. He is marathoner and hiker by passion. Welcome, Dr. Kukreti. Next slide, please. Professor Mohan Dhani, currently Professor and HOD of Sri Guru Ram Rai Institute of Medical Health Sciences, certified rater for many international multicentric studies, over 50 peer-reviewed articles, over 1,000 citations, HI index is 20. He is principal inspector in many RCTs. Welcome, Dr. Dhani. Now I hand over the meeting to the chairpersons, Dr. Kukreti and Dr. Dhani. Both of you tell a little about the topic, and one has to introduce the speaker, that is Dr. Rasapur Bipeta. His CV is on screen.
Good evening, everyone, and welcome to this wonderful session of Thursday Musing. And this is a topic that has been chosen today, the rating scales in psychiatry. So just like rating scales in psychiatry are instruments, and just as other medical instruments, they help in screening, diagnosing, finding out the severity of the disorders, and ultimately see what recovery is in different areas. And just like other instruments, we have to choose the instruments carefully. Some instruments, like you can say weighing machine, glucometer, that can be used by even the health workers, but certain like stethoscope or the ultrasonography machine, they require some expertise. So unfortunately, that say awareness is missing, and many times rating scales, because they are easily available, are used by everyone and end up in erroneous usage. So this topic for today is very apt, and I think Dr. Rajshekhar Vipeta is going to speak on it and enlighten us with this. So over to Dr. Prerna.
We are very delighted to welcome Dr. Rajshekhar sir. Sir is Professor and Head of Department of Psychiatry, Government Medical College, Meerut, Telangana. Sir is a very apt speaker, being the Editor-in-Chief for Indian Journal of Psychological Medicine and IPS South Zonal Branch. This topic usually whenever comes, it often strikes the first thing that comes to the mind is that, is it only something that is for just PG thesis, research work or clinical trials? But then, yes, we also come across a lot of patients and families giving different opinion about the rate of improvement. Even the rate of improvement and management differs across the clinicians. So somewhere, yes, rating scales do strike a balance by giving us a good measurable tool, but also sometimes it generates the concerns about it being over high, measuring more than what it tends to measure. Sometimes in cases of screening tool, it does raises the dilemma in cases of false positivity. But how to strike a perfect balance? Let's hear right from the expert's mouth. So please over to you, Dr. Shikhar sir.
Respected chairpersons, can you hear me?
Yes, sir, you're audible.
Yeah, respected chairpersons, my seniors and dear colleagues, I wish to thank Thursday Musings for inviting me. I think this is for the third time, and I think it has been going on very well for past so many years. I congratulate all of you. So I'm going to talk about rating scales in mental health. I have a conflict of interest here in the sense that I'm a very, very hardcore supporter of rating scales. And during my postgraduate training, as well as in clinical practice, also I had an opportunity to work under Dr. Majid Khan at a city nursing home, Hyderabad. So, sir actually used to refer patients. Refer means I used to work in his clinic, and then after doing a preliminary assessment, sir used to ask me to see all the patients and then do all the ratings. So, I would say that I have had little experience in this field, and I'm a very avid supporter of rating scales, assessment schedules, and in all that, and that is one of my areas of interest. Having said that, my presentation is not going to be biased in this particular field. This way, just because I support this does not mean that I'm going to favor this particular talk. So, what are rating scales? This is basically a systematic approach to quantifying the qualitative aspects of mental health. So this is a very important statement because what we see, like we know that mental health is very, very abstract. And here in rating scales, what we are trying to do is we are trying to quantify something through numbers, something which is very, very qualitative. So this is what rating scales want to do. And these are objective and a standardized language for describing the symptom severity, means how severe the symptoms are, what is the impairment in functioning, and what is the treatment response, and also prognosis. So this is what rating scales are supposed to do. So there's a dominance in mental health research and clinical assessment because of efficiency in quantifying complex psychological symptoms into numerical data. So if you see this slide here, this is a study by Fred et al. 2022 who found that if you see the combined citations, HAM-D with BDI, there are more than 80,000 plus citations. When you just take these two instruments, depression rating instruments, if you see the other depression scales as such, it is around 280 plus. So this actually talks how much these instruments actually are used in our research area. So why it is important? Because this is mandatory for clinical trials, grant applications, and outcome studies. So the regulatory agencies, especially FDA, is not going to give drug approval unless we use something which is, unless we say that a particular drug actually has fared well or did not fare well on a particular instrument. It is understandable because rating scales are reproducible, they are amenable to statistical analysis, and most importantly, they give uh, objectively they will tell us like what they basically mean. So it has become rating scale has actually what it has done, it has made subjective experiences to objective phenomenon. And integration of rating scales into mental health practice is one of the most significant methodological shifts in modern mental health care. So if you see the initial period when probably when psychiatry or mental health was actually evolving, probably there were not many rating scales. But as the understanding of psychiatry grew, psychiatry I mean mental health in general. So there's actually a parallel uh, understanding and improvement of rating scales or the things in particular field in this particular field. And movement towards quantification actually mirrors how it has happened in other medical specialties. For example, in if a person has diabetes, so the physician actually wants to show to the patient, see, you are having an increased blood sugar on 3 different occasions, so that is why you have diabetes. So similarly, a parallel movement started in mental health where they actually wanted to have an objective uh, measure which could actually tell the patients, tell the regulatory authorities, or tell other people that there is a even quantification is possible in mental health. And why it is important? Because we don't have biomarkers or reliable lab tests which can actually guide diagnosis and also how to monitor treatment. Also, subjective assessment leads to variability in clinical decision making and hampers the research effort. So that is why rating scales are so important. So what is the aim of scales? It aims to address these limitations by providing reproducible, quantifiable data that could be tracked longitudinally and also compared across different patients and settings. For example, if I'm a psychiatrist sitting in Telangana and there is another psychiatrist sitting in Delhi, so both people should be able to use the same rating scale on same types of patients. So that is why scales are so important in mental health. So why rating scales matter? Because they give objective measurement. They help us do the monitoring and treatment. Also, it is a way of communication, like how to communicate. For example, if I'm saying then on ham D, the person is mildly depressed, so a psychiatrist who is sitting or a psychologist sitting somewhere in US should actually understand what this mild depression means. So it is actually to improve, to encourage communication between two mental health professionals. And most important, it is for the advancement of research. So objective measurement has become a medical imperative. So what is the analogy? Like just as cardiologists say that BP and measurements are important to diagnose hypertension and titrate medication, psychiatrists benefit by quantifying symptom severity to track treatment effectiveness and guide clinical decision. So basically, this is based on the medical model framework, and the scales in mental health have become an art, and later it has actually evolved into a science. So the proponents of rating scales that say that without objective measurement, clinicians actually lack reliable feedback on whether interventions are working. For example, I see a patient, we all of us know, I don't know whether all of you people also have observed something unique I have observed with OCD patients. When they come first time to us, they're very severely distressed with their OCD symptoms and all that. But as the time progresses down the line, they say, no, it was nothing like that. I was always like this. So somehow, for some vague reason, I have found that people with OCD actually do not, first of all, appreciate improvement. If at all they say that they're improving, they say it is because of their own uh, whatever efforts they have made or for whatever reason. And also many times they actually denied that there was an improvement. So probably this is a very intrinsic to the OC symptoms, like doubting themselves, the pathological doubt, doubting the clinician. Doubting means I'm not talking for the paranoia aspect, but that not able to actually uh, the, uh, like uh, uh, by doubt I mean they are not sure about things. So when we have a rating scale score on different occasions, we can actually objectively tell the patient that, see, this is why your Y-box score at baseline, and this is how it has fared down the line. So that is how rating scales actually are very important for giving a reliable feedback, and very important. Now we live in the era of Mental Health Care Act 2017. And even before, we used to go to courts and all that. So if we have an objective assessment, for example, in a person with schizophrenia, if we have a PAN score, we can actually tell the honorable magistrate, see, this is what the PANS score was there at the admission, and this is how the patient has improved. And this is the PANS score at the time of discharge. So this is an objective way to tell our own colleagues, the authorities, the policy makers about the our illnesses. So it basically provides a common language for communicating about symptom severity, facilitates the quality improvement initiative, and enables systematic research. So we know that even in research, it is very, very important for us to have proper rating scales. So when we talk about rating scales, now I'm going to use a better term, which is called measurement-based care, MBC. So MBC is the acronym. So a common term which is used to denote rating scales is actually MBC, that is measurement-based care. So world over, there's an MBC movement going on which advocates for the routine use of standardized instruments to with a high quality of very, very important for high quality psychiatric practice. Now, I was talking about the adoption gap. Now, I have talked about like why rating scales are so important, but does it really actually translate into our routine clinical practice? We really doubt, because this particular slide says that despite compelling rationale, there's a disconnect between recommendation and reality. So, for example, these particular authors have said in their study that 58% of psychiatrists whom they surveyed had never used scales during their practice, and they had relied mostly on their clinical interviews and subjective impression. So the patient came to the hospital, to the OPD, and they did a clinical interview. I really doubt how many clinicians, very sorry to say that, but many of us actually say that, no, this is what my intuition says. But how much of us are actually using ICD-10 or DSM? I really doubt. But actually regulatory authorities or even government authorities say that we should have a proper diagnostic classification, whether we like it or not. So for example, we are a WHO country, we need to have ICD-10 or 11. So we mostly say that we are relying our assessment or diagnosis based on clinical interview and also subjective impression. So the authors concluded that rating scales, however logical, have not yet overcome significant practical, philosophical, or cultural barriers. So can we reduce one very important criticism of rating scale is, can we reduce the complexity of mental suffering to numerical scores, is what the people who oppose rating scales say that. So there's a huge adoption gap between what actually the guidelines say and what we do in our routine practice. So there's nothing to feel very sorry about it, because I remember around 15 years back, I was writing a review article with one of my co-authors on metabolic syndrome. So I was really surprised to read that despite WHO's recommendation for general physicians that waist hip ratio should be measured at every visit, many people, many general physicians, even in a developed country like different developed countries, don't do that. So there's a huge gap between what the guidelines recommend and what we do in our routine clinical practice. So measurement-based care talks about the collaborative model. So what is the collaborative care framework? Scales function most effectively not as isolation tools, but as an integral component of a comprehensive care delivery system. They talk about a systematic approach where they say that we have to integrate scales into every phase of patient care. When from the initial assessment, means the day the patient walks into our clinic, throughout the period when he is with our treatment, and also for adjusting the treatment. So the day the patient walks in, till the patient is with us, we have to actually do rating scales. So what it emphasizes is that there is a routine collection of patient-reported outcomes using validated instruments with results directly informing the real-time clinical decision-making rather than serving merely as research data or documentation requirement. So what it says is that there's a need for rating scales, not just because we want to do some research or just because our authorities want us to do this documentation, but also in our day-to-day clinical practice, we need to have routine collection of patient-reported outcomes. So this collaborative care framework actually recommends that it has to be integrated across different settings. For example, even at a basic primary care, there's a need for symptom monitoring using scales. For example, a very, very brief instrument such as PHQ-9, which is very well validated for primary care population. So our general physicians, even an MBBS doctor, or say a psychologist, or say a social worker should be in a position to administer PHQ-9 in a primary care setup. Patient-centered outcomes, patients are better reporters of their internal feelings. And also APA says that MBC is the best practice. So now we are getting a lot of endorsements from various authorities saying that rating scales are very important. So, for example, it is found that improved treatment outcome actually can be measured with scales. If we see the depression outcomes, it is found that routine administration of scales such as HAM-D and all that actually guides medication adjustment, psychotherapy modifications, and also refers to specialty care. And patients achieve symptomatic improvement and more rapidly and completely than under usual conditions. So, what are the reasons? We are able to we can identify very early that there is an inadequate treatment response. We can give this is what I was telling, that we can actually provide a feedback to the patient and there is a reduction of the recall bias. For example, I saw a patient 1 month back. I may not actually remember how the patient was that time. So having a score there actually can help us track 1 month later, okay, the HAM-D score was so much and now today is this much. So I can actually, this can prevent recall bias even on my part. And it can help treatment decision based on actual symptom trajectories rather than based on subjective experience. So this is a Cochrane systematic review of lot of RCTs which found that collaborative core module with outcome measurement using scales is significantly better when they use depression and anxiety outcomes, and effect sizes were clinically meaningful. So this actually shaped the healthcare policies. So based on this Cochrane systematic review, this is CMMS, Centers for Medicare and Medicaid Services, actually has now incorporated reimbursement codes based on this Cochrane systematic review findings. So what this particular organization wants is that in their routine notes, mental health professionals actually should be using this rating scale scores and how the person is actually faring across time. So patient-related rated scales outperform the clinician ratings. For example, it was found that PHQ-9 and GAD-7 was actually true positive, means it was very high, it was highly sensitive, means 94% true sensitivity was there when it came to as regards PHQ-9 and GAD-7. True sensitivity means more people uh, with symptoms were able to be detected. Means we know that if the sensitivity is high, if a rating scale sensitivity is high, the true positivity is more. So PHQ-9 and GAD-7 was more able to detect depression and anxiety disorders and was able to correctly identify nearly all true cases when compared against the structured diagnostic interview. Meaning, when in a particular person, when they have used PHQ-9 vis-a-vis, say, ICD-10 diagnostic interview for diagnosing depression, they found that PHQ-9 was able to detect the presence of depression in around 94% of cases. So this is very, very encouraging. This is in contrast to the 88% sensitivity when they had used clinician administered instruments. So we know that PHQ-9 and GAD-7 are actually patient rated instruments. In contrast, the clinician rated administered instruments such as MINI or say CIDI, these are clinician rated instruments. So it was found that patient rated instruments are more able to detect mental health morbidity as compared to clinician administered instruments. So this is a very important slide. But what happened was the sensitivity fell down to 77% as regards cognitive assessment batteries. So when they have used cognitive assessment batteries, they found that there was a very high chance that true cases were actually missed. So what does it mean? That cognitive testing alone is not sufficient. We need to incorporate a detailed clinical interview also when we talk about cognitive assessment. So please remember, when we talk about cognitive assessment, it is not related to cognitive assessment which is part of dementia or in the context of certain neurological disorder. Here, cognitive assessment is in the context of various psychiatric illnesses. We know that many patients with schizophrenia, even bipolar disorder in the interepisodic phase have a lot of cognitive symptoms. So this particular slide is about cognitive symptoms in that particular context. So what is the implication of this slide? The implication is that brief, self-administered instruments are able to capture patient experiences better than the lengthier clinician-rated scales. Reasons, what are the reasons for this? Patients can actually reflect better when they are independent and in a written format. It means uh, when they when patients are given rating scales, self-rated rating scales such as Beck's depression inventory or PHQ-9 and all that, they can actually reflect their subjective experiences better compared to a clinician administered instruments such as HAMD or MADRS. So what are the advantages? The advantages are that it needs minimal clinician time and it can be even done through apps or smartphone apps. So this particular slide talks about the patient rated instruments vis-a-vis the clinician rated instruments. Now rating scales in clinical practice give an objective assessment to examine how frequently. So this particular paper was actually published in our journal, Indian Journal of Psychological Medicine. I'm not sure how many such studies are published in Indian Journal, but this article was published in 2025. This was from Tamil Nadu. These authors did a retrospective chart review of all the medical records of persons with mental illnesses who were admitted in their hospital. So what did they want to do? They wanted to examine how frequently psychiatric rating scales were used in inpatient care. So they found that only 54% of patients had a baseline rating scale administration, which was actually dismally low in contrast to what is actually recommended in the international guidelines. And at baseline it was 54%, but it actually fell down throughout admission. It fell down to 42% at first week and even lower later. So what the authors concluded is that there is a low and decreasing utilization of scales. I still remember, like when I was doing my post-graduation, for every patient, we used to do rating scales, and it was mandatory in our PG curriculum. But down the line, unfortunately, I think throughout the country, it has come down. I think as teachers, we need to take a care of this. We need to train our postgraduates in administering rating scales. So there's a low and decreasing utilization of scales, which is actually not very encouraging. So what is the authors conclude that there's a need for training and implementation of scales to improve the patient care. So this is one paper which was published in our journal. So now coming to the slides. So we sometimes wonder why actually clinicians do not use rating scales. So there are a lot of barriers to this: individual barriers, institutional barriers, and systematic levels. So sorry to say, I think many of us, especially psychiatrists, feel that rating scales are useless. But let me say that just because I don't know how to do it does not mean that it is useless. I think same thing even applies to psychotherapy. Just because I don't know how to do psychotherapy does not mean psychotherapy does not work. So let me put it very, very point blank. So just because I don't know how to do rating scales does not mean that they don't work. So there are a lot of barriers actually. I think these are attitudinal barriers on our part, institutional barriers wherein as institutes or as teaching colleges or medical colleges, we are actually not asking our faculty and students to do that, and definitely systematic level issues. So there's a lack of training. Training before the MBC became prominent in the curricula. So many of our faculty members, including postgraduates, are not familiar with instruments. They are uncertain about score interpretation. For example, they just want to do some rating scale only when they are doing some research. Suppose they want to publish somewhere, but otherwise, during their routine clinical practice, they are not doing any rating instruments. There's a lack of confidence in using quantitative data over traditional subjective assessment. I think it is much more easier to just do a brief clinical interview than taking a HAMD in our scale, HAMD in our hand, and doing that assessment. I think there is a very huge attitudinal issue here. Time constraint, definitely I understand, especially in a private OPD. So we may take around 15 to 30 minutes to decide what medication to write to our patient. So there's a less focus on scale, because many clinicians feel that if you start doing scales, it will actually reduce the rapport and it will reduce the therapeutic compliance, which is actually far from true. Skepticism about the utility. Clinical judgment provides sufficient information, and they view that quantitative measures are less nuanced than the clinical interviewing. So many of our colleagues feel that my clinical judgment says that this is depression. So I actually, as soon as the patient walked inside the room, actually I could make out my precox feeling told me that this is schizophrenia. So we actually give a lot of importance to what we feel or what we believe than what actually the evidence says. Many of us actually wonder whether scales actually capture the aspects of mental health that they consider most relevant to treatment decisions. So there's a limited implementation. Only 13% of clinicians reported measurement-based care at every visit, despite awareness of professional recommendations. This is not the data from our country. This is data from other countries where they found that only 13% of clinicians are actually doing measurement-based care at every visit, despite they know that this is actually included in their guidance. So what does it suggest? That even clinicians who occasionally employ scales are not consistent. So this is what the study in our journal has shown, that though these scales were done at baseline, so during the course of admission, it actually fell down. So even those who are using are actually not yet doing it consistently. So having talked so good about rating scales, let me make a very provocative statement. Worth pondering, our rating scales are actually giving an illusion of precision. There's a huge criticism of rating scales, and this lot of criticism actually comes from psychiatrists. What they say is, if a scale has improved by 3 points, does it mean that the patient has improved? Are we measuring illness or question behavior? For example, if a HAM-D score of 23, we are saying, so by saying HAM-D score of 23, what are we measuring? Are we measuring a question behavior or are we measuring the illness? So when did numbers replace the narratives? Are we actually not focusing on the narratives of patients? And when did scores become disorders? So these are the major criticisms of rating scales. Why this is important? Because regulatory approvals actually depend on scale outcomes. Like it or not, but many of the regulatory agencies, even for example, US FDA, or for example, if you are doing some study in India, DCGI actually wants that we should do rating scales in a study. Guidelines actually rely on scale-defined remission. If we see various guidelines like NICE guidelines or CANMET guidelines, I think most of the places, they talk about if the score did not fall less than this, so please start this. So like it or not, many guidelines are actually talking about scale-defined remission or recovery. And disability certification. We know that IDEA score more than 40% is the cutoff for getting disability benefits. So like it or not, our authorities actually want us to do a rating scale, for example, IDEAs. So what is the criticism of rating scale? They say that it is actually oversimplifying. I still remember this one patient who is under my care for past few months. He was initially treated in US, and he has multitude of symptoms. He has lot of paranoia, delusions of persecution. He has few autistic features. He has issues with focus. Then he has a lot of problems actually. He has been diagnosed differently by different psychiatrists in US, even in India. Somebody has diagnosed as BPAD, somebody has diagnosed as autism, spectrum disorder, something. So I'm really confused. And now this boy who is around, I think 25-year-old, he's he read somewhere on the net that less concentration actually indicates ADHD. Now, last visit, around I think 10 days back, he came to me saying that he has ADHD and he wants Ritalin. So I said, in my clinical assessment, you do not have ADHD. But then he was very angry. He walked out of the room. So this is the problem with rating scales. When people self-diagnose and they actually challenge the professional judgment. So I think this is one of the big problems with rating scales. So the fundamental epistemological question is, can complex multidimensional nature of mental suffering be adequately represented through numerical scores? Can we reduce the human suffering to scores is a basic fundamental question. The criticism is that we are reducing phenomenological experiences to quantitative measures, and we risk losing what is most essential in understanding mental illnesses. What is very important? These are the three things which are very, very important in understanding mental illness. First is the meaning of the symptoms within each patient's life context. For example, a patient with depression A B patient with depression would be different. So the person's life context would be different. So A patient with depression who is having a 23 score on HAM-D cannot be equated with a B patient with depression who has score of HAM-D. So this is one of the major criticism of depression rating scale. Another is nuanced fluctuations in emotional experiences. People can have a lot of fluctuations even during the course of day, which actually rating scales do not capture. Then there are a lot of interpersonal dynamics, which again rating scales cannot capture. So this is the criticism of rating scales. So what are the cardinal errors? Actually, this is a very, very good paper. Who has, I encourage all of you to read this, 2022. It says that there's a basic cardinal error with rating scales. There's a conflational problem. We are actually mixing up experiences and behaviors of our patients with scores and ratings. It is like saying that he has given an analogy. He says that thermometer reading is temperature rather than a representation of it. Meaning a HAM-D score, HAM-D is actually depression than a representation of depression. So that is the problem with rating scales. When we equate HAM-D score of 23 with experience of depression, we reduce complex issue into just one number. So this is a major problem. It says that we're actually not giving importance to patients' subjective experiences, which can be better captured by doing a clinical interview. And he also talks about reductionism. He says that we are actually oversimplifying complex human mental states into simple numbers, which can be added, average, we can give mean, median, mode, we can even give SDs. So that is a criticism. So what is the clinical implication? For example, if one of a patient comes and he has a HAM-D score of 14 or higher, so should I start him on antidepressant? I think that is what rating scales are telling us. In contrast, if my clinical experience says, if my clinical interview says that actually this person actually does not have depression. So this is a problem. So clinical implication is very huge with rating scale score interpretation. So there are various logical and methodological problems with this, which Uhar has pointed out. He has talked about operationalism errors. He says that we are defining depression by HAM-D measures. Now, one of the problem what happens is, especially I have seen, especially as the editor of our journal, many times, sorry to say, but many of our non-psychiatrist colleagues, they are actually, I have seen this is, I think many of the editors, Alim Siddiqui are also is an editor and all that. What many times people do from other specialties is they will go to the college, a medical college, they'll use HAM-D on 100 medical students, and then they will say that so many 30% of the medical colleges were depressed, failing to remember that HAM-D cannot be done unless we are doing a face-to-face interview. HAM-D is a clinician-rated instrument. So in such a scenario, we should use PHQ-9. So that is a problem actually. We are defining depression by HAM-D measures. Even when psychiatrists are doing, I have seen papers where they say that, okay, because the HAM-D score is more than this is depression. Though actually the guidelines are very clear. Guidelines say that your diagnosis has to be based on the clinical interview, which has to be confirmed by either many or CD, and then you have to rate the severity of illness by HAM-D or BDI. So these are operationalism error. Naive language use. Rating scales assume that feeling sad means the same thing to everyone. So if a person is saying feeling sad, it is same as a B person feeling sad. And we know that it is actually different. And quantifactionism, believing that all psychological experience can become numbers. Now, if we see the sleep related problem, if we see the HAM-D instrument, sedative improves score without improving the mood. This is actually one of the, I think senior psychiatrists would know, this was one problem with the quetiapine approval. When FDA had given quetiapine approval for bipolar, I think that was a which study, Embolden study, I think. If I'm not sure about that. Quetiapine was approved for use in bipolar, and they found that later researchers found actually it was not because the illness had improved. What quetiapine did actually was it had improved the sleep item of that particular scale. So this is a major issue with rating scales. So a particular drug can actually improve only one aspect of the scale, and it can erroneously show as a major improvement on that particular score on the whole if you see the total score. So what now they have done is they sometimes do item-wise analysis. But fortunately, what happened is later the sponsors of this quetiapine trial went back and they actually did an item-wise analysis, and they still found that quetiapine, even after controlling for sleep-related item, was still found to be effective in bipolar. So that is the. But having said that, I think this thing we should remember. Item-wise scores are also very important. So there can be a pharmacological artifact. It inflates the apparent antidepressant effect also, and we have to be very wary of this. Now, if you see the depression-related scales, there are more than 280 scales related to depression. So does it mean that we are actually doing a lot of scientific progress? The people who oppose rating scales actually say that it is not scientific progress, but this is basically a measurement failure. Probably we are not able to understand how what depression is, and the problem is not with the instruments, but in the rating scale paradigm itself. So also the issue of inter-rater reliability studies. They say that like a chairperson actually has undergone inter-rater reliability studies and all that, and even I have undergone. So we know that what they do, they actually take us to investigate a meeting, and then they will see that all the people who are the raters, who are the investigators, they sit in a big hall, and then they will show one dummy case, and they will ask the all of us to do the assessment, and then they will see how the scores are different or same. So that is how they actually establish inter-rater reliability. So the opponents say that there is actually a lot of diagnostic agreement between experience, but actually it just exceeds the chance level. Though they are agreeing to the score, it is just a chance level, is what the people who actually oppose this say. And they also say that when two trained clinicians assess the same patient using the same diagnostic criteria, they reach different conclusions. So the measurement approaches are basically failing to capture a stable observable reality. So this is another criticism of rating scales. They say that though we have so many rating scales, there is not one rating scale which is actually assessing the symptoms properly. What is the other risk of oversimplification? The loss of nuance. So mental states exist along multiple dimensions: phenomenological, intensity of symptoms, how long we had this problem, functional impact, personal meaning, existential significance. All this cannot be captured by numericals. Patient who might score identically on depression scale of 2 time points while experiencing qualitatively different forms of suffering can be different. So what it basically means is, I was telling some time back also, a HAM-D of 18 for one person may not be equal to HAM-D 18 of something else. So there like this, there are a lot of controversies, and they also talk about internal consistency, sensitivity change and all that. They are saying that this is a big farce with rating scales. So what they are saying is that clinical interviews allow exploration of these qualitative distinctions and actually help us and to overcome these issues. So what is the recommendation? They say that rating scale should be used with caution, and though it is found to be very useful in research, in clinical practice they may fail. And another criticism with rating scales are they may be lengthy, they assess constructs which are not directly relevant to treatment planning, and they generate scores where clinical significance remains unclear. Okay, so these concerns do not invalidate rating scales but suggest that there is a need for comprehensive clinical assessment. So the bottom line is we should use rating scales with lot of clarity and judiciously. So what is the best way to choose a rating scale? We have a lot of rating scales, but our best scale should be based on the condition which is assessed. For example, when we talk about depression, I think many of us know that MADRS HAM-D actually is not able to, like when people with depression have a lot of somatic complaints, for example, somatic complaints in the sense lot of aches and pains, actually they say that HAM-D is not very apt instrument for diagnosing depression in people who are medically ill. So in such people who are medically ill or in general medicine OPD or setup, they say that MADRS is a better instrument. So the condition what we are assessed actually determines the rating scales we have to use. The time and resources, how whether we have a lot of time, what resources we have, actually also will determine what scale to use. Patient literacy and language proficiency, this is very important because many of our scales, though now there are a lot of efforts to standardize in India, but still many of our rating scales are not for our population. And they should inform clinical decisions, documentation research. For what purpose we are using, a rating scale? Is it to inform a clinical decision, to document something in our roads, or is it for research? Goal is for diagnostic screening or symptom monitoring. Patient population, for example, yeah, this is another problem. For example, I'm very, very careful when a paper comes to me. For example, if a general medicine uh, professional has used PHQ-9 to screen depression in his busy OPD, I would probably consider that paper in contrast to a psychiatry professional who is using PHQ-9. So there's a very major issue here. So what patient population we are using, who is using it, also makes a difference. And generally it is found that in a primary care setup where there are a lot of patients, where it is very difficult to do face-to-face interviews, probably PHQ-9 is better. While in a tertiary care or a GHPU, probably HAMD and such cares are important. Also another mode, whether we are going to do online service or face-to-face interviews. Now this is all of us know that there are a lot of scales, diagnostic and symptom based and all that. So I'm not going to go to this slide. Yeah. So there are, let me just talk briefly about self-reported and clinician-rated scales. The self-reported scales, they lead to less response bias. Sorry, they can be used, the self-report scales can be used for large population. For example, when the patient is waiting for us for a consultation, that is a place where we can use such instruments like BDI, PHQ-9 or CESD, that is the Center for Epidemiological CSD is a very well validated scale. The problem is response bias, literacy can affect, and also the person's mood state can actually affect. Clinician rated instrument should be used when there is a need for professional judgment. The advantages of clinician rated instrument, for example, HAMD, is when we need to take a lot of non-verbal behaviors into account, where there is a need for an expert, and also it is when the responses are very, very ambiguous, and also in the research context. So we know that HAMD and all that are clinician rated instrument. The only problem with clinician rated instrument is that it can lead to a lot of rater bias. For example, if I'm a psychiatrist who is treating a patient with depression, I may have my inherent bias into how am I evaluating the response. So there's a rater bias with clinician rated scales. So the optimal strategy is self-report scales in addition to clinician rated instrument. This is what these authors propose. So now even FDA actually wants that trials actually should use clinician rated instruments in conjunction with patient reported instruments. So that is how we can get a comprehensive assessment of the patient's condition. Okay, so I'm not going to talk much about this, but we can use a brief scale such as PHQ-9 when there is a broad patient population and condition specific instrument. For example, HAMD, for example, when to choose medication, all that, when we want to have a clinical decision making. Also, now we are talking about digital and AI enhanced assessment. Remote symptom tracking can be done through smartphone enabled patient rated scales. It can actually give rich longitudinal data. For example, patient has come to us baseline, and again patient is going to come after say 1 month. So in between, what happened to patient? Patient can actually use smartphone based apps which have inherent scales to monitor the improvement, and this can be actually uh, uh, it can be incorporated into the EHRs. So this is found to be very useful for disorders which have recurrent course. For example, bipolar disorder, recurrent depressive disorder. When people are in remission, so to see whether they are relapsing or recurring, there also such remote symptom tracking is found to be useful. Also, telepsychiatry is an in thing now. Now we are having a lot of telepsychiatry related scales also. The only concern is about data privacy. It gives a lot of importance to algorithms and limited direct human interaction. Now even AI based apps are there which can actually amalgamate patient reported instruments, this remote symptom tracking with our assessments, and they can actually give us algorithms. So what is optimal? They say that we should use digital tools in combination with clinical judgment. So what is the future of mental health assessment measurement? There are a lot of pressures from healthcare payers, regulatory bodies, and like it or not, we have to use rating scales in our day-to-day practice. For example, I was talking about the CMS, not yet in India, but I think very soon it will come into India. Around 10-15 years back, I had written an editorial. That was the time when that was the time when MCI said that CME credit hours are going to be mandatory. So our people started saying, how can you make credit hours mandatory? This is not apt for this country. But now, 10 years later, credit hours are now mandatory. So I think we have to be prepared for it. Same happened with promotions publication. 15 years back, when MCI said that promotion assistant to associate to professor, we need to have 2 publications. Our people said, what is this? We do not have resources. But now for promotions, it is mandatory. So it is high time we have to understand that there is a lot of pressure in other countries, and very soon in India also it is going to come. We have now Mental Health Care Act talks about insurance for the persons with mental illness. It is high time we should be aware of rating scales, because insurers actually would like us to document in our medical records how this person has fared over the course of admission and how the person has improved. So it is a documentation requirement. It is a reimbursement in it. So this is something. What CMS has done is for billing codes, it actually reimburses when people are doing rating scale assessment. So I think this is what should come into India also. Unfortunately, what happens is we just copy the West, but we do not do all this reimbursement part. So we have copied the West saying that publication is mandatory, but when it comes to funding for research, not many, I think, except for institutes like NIMHANS, AIMS, many of the hospitals, medical colleges, they don't want to fund researchers. So same is with this aspect also. I think once we have a billing code, even in India, it should be reimbursed. Quality standards, because MBC actually talks about high quality practice, and it is what is going to be the accreditation standard. Now we have NABH and all that. Probably down the line, NABH also would see. I still remember when I was at my previous place of posting at Gandhi Medical College, Secunderabad in Telangana, the NMC inspector, the erstwhile MCI inspector came and said, how are you coding? Are you using ICD-10 codes? Are you writing in the case sheets? So I think it's going to be, when it comes to rating scales also, that is what will happen when we talk about NABH accreditation of our hospitals. They are also going to see for psychiatry, especially for psychiatric hospitals and nursing homes, whether we are using rating scale scores to monitor patient progress. So what is important? There is a need to balance the quantitative and qualitative insight. By quantitative, I mean rating scale scores. Qualitative means our clinical interview. So this is the most sophisticated vision. It is a very, very important thing to preserve patient narratives through use of rating scales, which are there self-rated. And at the same time, we need to interpret in what context it is there. So a score should that contradicts clinical impression also should explore the other causation. For example, I was talking about this person who said that on ADHD self-rating scale, he was scoring very high. But then when I asked him, except for less focus, he was not having any other, on clinical interview, he did not have any other symptom of ADHD. I said, I'm not going to give. I told, just because you are asking, I am not going to prescribe methylphenidate. I think we have to look into the context. The rating scales have to be interpreted into the, it should be a contextual interpretation. I think that is very, very important. Like it or not, measurement based care is going to be very, very much there, regardless of whether we find it useful. Hence, let's be prepared. There's a need to educate clinicians, especially as teachers. We need to encourage our PGs. Definitely, I have seen in my unit when I was at my earlier place of posting at IMH Hyderabad, in my OPD, especially for people who used to come to from courts and all that, I used to make it mandatory. All my patients in forensic wards used to have a uh, rating scale score at baseline and also at the time of discharge and throughout, especially when we used to get patients related to fitness to stand trial. And because that is what courts are going to ask us, how did you do the assessment? How do you know patient has improved? And we need to design workflows, provide user-friendly technological infrastructure. Very, very important. There's a need for reimbursement, because unless there is a financial incentive, I think it's not going to work. There's a need to foster a clinical culture that values systematic outcome monitoring as integral to high quality care. Use of rating scale requires understanding their limitations and maintaining clinical judgment. So we should use rating scales in the context of our clinical interview. So this is my last slide. These slides are not mine. I have used certain AI tools like Gamma and AI and ChatGPT to generate the structure, talking points, and few images. And this is one very good book. This is one of the very few books from India on rating scales and assessment scales edited by me and Dr. Vikas Menon. It was a very good initiative of Indian Psychiatric Society South Zone branch. I have provided the link. Actually, we have authors from all over the country, I think including Shobit Garg and all that. So here we have written rating scales are important important tools. However, there is so much of disillusionment in us. Reasons could be many. There's a lack of exposure during PG training. There's a lack of faith in the scales, time constraints, a lack of knowledge about the proper scales to use, uncertainty about patient complaints or change, perception that rating scales are to be used only in research settings. However, these also have been those who have been using various rating scales know that it actually works. So this is the statement from this particular author who say that systematic outcome monitoring becomes not just best practice but expected practice. So various authorities, uh, regulatory authorities, drug trials, all that actually want us in our clinical practice, also in research, also in everywhere, that we must use rating scales in our day-to-day practice. Thank you.
Thank you, sir. Thank you so much. We are rating your presentation to be very high. So
Thank you.
it was actually a very useful presentation, I think, and good revisit to the concepts for people who are not in academics. So I think we should have a huge round of question and answer in this. So thank you, sir, and over to chairpersons for their opening remarks. You can stop the screen share, sir.
Yeah.
Chairpersons, any opening
So,
remarks?
thank you. Thank you very much, sir. A very nice presentation, very lucid. Rating scales are very emotive, and you can say they emote a lot of reactions from everyone. I have 2 points on which I would want your thoughts. One is the gold standard for any measurement. So that still is a clinical diagnosis. That still is a clinical assessment. Like if you see whether a rating scale, if I come up with a rating scale, whether it works or not. So I have to assess it with a gold standard is the clinical assessment, right? So all the rating scales, they have been measured against clinical diagnosis, clinical assessment. So it is difficult to see that they will replace the clinical assessment. And second point I want to ask you about is the choice of rating scales. So if you choose a weighing machine to measure blood sugar, it is not going to work. So if I am using HAMD to measure, say, diagnose depression, and clinically I know that the patient is schizophrenia or adjustment disorder or even insomnia, so HAMD scores may come up high, and it will give an impression that the person is having depression. So choice of a rating scale, that is very important in using appropriate tools, which are, in my opinion, very effective in measuring what you want to measure. So on these two, if you could enlighten us.
Yeah. So regarding the first aspect, uh, there is no doubt. I'm not saying that clinical interview is not important. There's an undeniable clinical diagnostic thing is very important, because I think all of us know that we are all psychiatrists. Mental health, our specialty is the only specialty where interview is therapeutic. So many of our patients actually improve when we talk to them and when we are diagnosing them. So there's no doubt about it, first. Second is, you have rightly said that all the rating scales have been validated against gold standard, which has been clinical interview. That is second. Third is about
Choice of rating
yeah,
scales for
yeah. Before that, for the first question, third very important point. If you see the international studies, what they say is they want us to say that I have made a diagnosis of schizophrenia based on clinical interview confirmed on Mini. So
Right. Right.
such statement in a research study actually adds a lot of value.
Yes.
The problem here, what has happened is Mini actually now is no more in public domain. So I think that is a problem. I think even CIDI is not free. So that is that.
Yes.
So that is
That is true.
yeah, it is an undeniable truth that diagnostic interview has a place. It will be there. That is first
Right.
part. Second, sir, actually to choose a rating scale, even now I think HAMD and MADRS and BDI are the best, sir. And when it comes to large populations, PHQ-9 and CESD. And one very good thing about CESD and PHQ-9 here are they are free of cost. The problem
Right.
with BDI is no more free. I think
Right.
it was never free. I think that is how we had to
Right.
decide like whether which one is free for use and copyrighted and all that. And Madras, I have found that at least through the literature also, Madras is more useful when we want to do in a general medical OPD or say in
Yes. Somatics. There are more
somatic.
somatic symptoms.
Yeah, yeah.
Right.
And HAMD definitely. So about one thing, this is what we have mentioned in our book also, which I was telling. Like there was a chapter with Vikas Menon and Sandeep Grover. So the advantage with a rating scale, for example, if we see the clinical interview just says decreased sleep. But if we go to the
Right.
HAMD item of decreased sleep, it will talk about three domains. Those four things. I think
Right.
a rating
Right.
scale gives lot of value. It should be used in conjunction. Clinical interview with rating scale, and we should not just giving a score. We should see what each item has there. So, for example, if any patient has initial insomnia on an item scale, insomnia rating scale, probably drugs such as anxiolytics, such as benzodiazepines would help. Suppose people have say short acting one, or people have maintenance of sleep, probably a little longer acting one. So these are few clinical nuances. I think the choice of antidepressant also depends on how good that rating scale is, and HAMD and MADRS are undoubtedly the best. There's no doubt about it, sir.
So
Yes.
I agree with you. Hamdi.
Uh,
Yeah.
Yeah, no, sir,
Yeah.
if I can add a point here, rating scales are not versus or anti to the clinical interview.
Right.
They're
Correct,
just a
correct.
part of clinical evaluation system.
Exactly.
Correct.
So we have to have both. We need to apply some parts. We need to quantify. It is very easy to quantify. Well, in fact, once I had to punish a JR, so I sent him to learn a scale. So he was taking the history, so some points are missing. So if you are able to learn a scale, your history taking improves so much because all the
Yes.
aspects you are able to touch, and then you are able
Yes.
to
Yes.
grade them up and down. So
It's a very
Yes.
important
it is
point.
very intertwined with history taking, with clinical interview. So I think very important part. And as sir said, fully agree to all points what Bipeta sir said. And it is being ignored. So sort of it has been branded as being elitist. So what I
Yes.
this is
Yes.
what I
Yes.
So one of the sir uses can be to improve our clinical dimensional assessments. Sir, the rating skills will give that. And so then I really like the name, sir. You say MBC based assessments. Sir, G. Prasad Rao sir wants to actually address. Sir, you can unmute yourself, sir.
Yeah. First of all, am I audible?
yes
Yes,
sir.
sir.
Yes, sir.
Yeah. Thank you. Thank you for this wonderful one. I would like to share with all of you my experience. Uh, I am I have done 119 clinical trials of US FDA. And you understand the latest part because most of this US FDA, and to just add to what Rajshekhar said, uh, on a very milder note, I would like to share with you the beautiful experience of rater training and rater qualification. And many times, and with due respects, the NIMANS faculty who were part of the trial and other AIMS trial were disqualified during the raters training when it used to happen on site for a rater training. And as Rajshekhar has said, they will show a video and we are supposed to rate, and that is not fitting into gold standard. So that is one component. But what I would really say is, I think the raters, see, if, for example, in my hospital, MMSC is a routine, AS is a routine for dementia, MADRS is for a repeated, not for a diagnostic. I think, see, again, we have to be very specific on what rating scale we have to use. And when Rajshekhar has said, he has hit the nail on the head, on the spot. When there are thousands of rating scales, the validity of each scale is compared with a golden standard and is still considered good. And we still keep getting new rating scales all the year. But the point is not that. I think there is no, no answer for a classical interview for diagnosis. And the rating scale, if at all, my own thing is, it is a repeated measure. It helps first in the first level, it helps in the severity, and at second level, it measures the improvement. I would also like to close my comment with most of the people would miss in the DSM-5 a 9-item rating scale, which can actually measure the severity of dementia, schizophrenia, psychosis. It has the depression score, it has the catatonia score, and that is a easy method to check the repeated measures. But see, and I also would like to close with what Rajshekhar commented. Only 25% of the psychiatrists would really use, and of course, you need to be using with kind of cognizance that it is utility and useful. But my own future, the immediate 10 years future would be is for the necessity of insurance, every one of us have to use a standardized rating scale.
Yes,
and
sir.
thank you, Rajshekhar, and thank you, Alim, and everyone.
Thank you, sir.
Thank you, Shobit, for that wonderful book, your wonderful PDF. I have that copy with me as well, and every one of you. Thank you.
Thank you. Thank
Rashika,
you.
sir, I also want to know your remarks on one thing that there is no denial about the utility of these scales. But will you agree that in the non-mental health professional setting, the use of scales, in fact, the development of scales is also not done so rigorously, especially in the educational settings. It's almost being oversold to make false diagnosis. Even some of the educational institutes want to use it as a checklist when somebody joins the institute. Some of the occupational organizations also ask for certain personality test, aptitude test. And in a way, yes, because it's not being done by a trained professional person or by persons with some vested interest, because it's ordered by the organizations, it does stigmatize people at times.
Yes, yes, Dr. Prerna, what you said is absolutely right. See, as an editor, like when a paper comes to us, you are also one of the authors of a journal. You are also peer reviewer. One of the first thing what I do is I open the title page and see who are the authors. I don't want to get biased by that. Why I want to see is, are they competent to do this study? So what you said is absolutely correct. The rating scales have been misused to mislabel people, and we know that mental health has been, psychiatry has been misused by a lot of people. So what you said is absolutely right, and it is very harmful in the hands of incompetent people, and that is what has happened even when it comes to internet addiction. One of my very favorite topics, internet addiction has been overdiagnosed by using YAT, that YDQ, Young's Diagnostic Questionnaire, going into a college, taking 500 students. And if you see, who are these investigators? They are not mental health professionals. They are librarians and all that. So I think the people who are doing that assessment is very important. They should be properly qualified. Very right.
Right. And so, yes, we all will agree that there is no dilemma when it comes to using the scales in research settings or in medical legal settings. Everybody wants to use it over there. But most of the places where house becomes divided is its clinical utility in day-to-day care. Still, there is a lot of resistance, and resistance is not because we think that it is unnecessary, but I genuinely feel as a clinician that it makes people uncomfortable.
Yeah.
As sir said, that it sometimes is taken as that, yes, it's reductionism, it's clinicians' judgment versus the scale. rather than using it as a tool, as an adjunct to help us actually gauge the clinical response and care. Because I'll share my own experience that when we were doing the drug trial for a treatment resistant schizophrenia, and when we actually measured it through scale, all the patients who were referred by clinicians as treatment resistant schizophrenia, we found that none of them could actually meet the measurement requirement even. So subjectivity definitely is lot there.
Yes.
And also the another experience where I faced that in the occupational setting, where I was asked to do a workplace fitness assessment because the person had residual symptoms of schizophrenia and grossly was appearing okay. So the organization was not at all ready to understand that delusion can have certain dimensions. When I showed them the Panas's rating scale, that
Yes.
look, people can have it at belief level, they still may not have acting out behavior, then yes, they could actually believe on it. Otherwise, right away, they disregarded it that yes, illness is not at all there, and person is just feigning that it cannot work. So definitely there are a lot of, it can be great help provided we remove our attitudinal barriers. And you very rightly said that we need to put it, incorporate it in our young trainees training. Till the time they
Yes.
see the utility, this resistance will continue.
Yeah, Dr. Prerna, two things what you said are absolutely right. First is the PANS. That is what I was trying to say. That see those scores, no. So that is what I was trying to say. Like, see that our clinical interview does not give. So PANS actually gives that. That is first part. Second, I feel the problem is with the teachers, not with the trainees. At least as head of the departments or head of the units, I think once you start doing it, it will go into the postgraduates. That's how we were trained, and that is how we have learned from our place where we were. Actually, Dr. Christina George is there in the audience. I see her. She is also from the same place. For every patient, we used to do rating scales. That's how we have learned. Yeah.
Sir, few basic questions that I'll go through, sir. If you can
Yeah.
answer them quickly.
Yes. Yes.
For the benefit of the audience, what is a subjective, sir, scale? What is an objective scale, sir? And then what is a clinician rated instrument, sir?
Yes. Sub. Yeah. Basically, there. Instead of going into that, I think there are mainly two things there. First is the patient or subject rated, and another is the uh, person rated, the professional rated. So yeah, clinician rated. So clinician, yeah. So when I say the reason I don't want to use the word clinician is because it can be any mental health professional, psychiatrist, psychologist, psychiatric social worker, a mental health nurse, or whoever it is. So professional rated and the patient rated. So when we say patient rated, so these scales such as PHQ-9 or say the CESD, or for that matter, the ADHD self-rated scale. These are all patient-rated instruments. In contrast to that, HAM-D, MADRS, they are all observer-rated, or say, for example, the professional-rated.
And as you said, sir, any clinical construct, ideally, we should have one patient rated scale and one
Yes.
clinician rated scale or observer rated scale. Sir, how
Yeah.
frequently to use these scales?
Yeah. See, one thing I'll tell you, for example, it can be so brief and it can be so useful. If we always say that we don't have time, I think especially people who are in private practice, they say we understand because they have such good OP, they have such high OP. But an instrument like clinical global impression, which is a very well validated instrument, even in FDA trials, CGI does not take more than a second. I think CGI at baseline, CGI-S, and CGI-S and I at every visit, I think that is at least minimum we can do. Sorry, Dr. Shobhi, did I answer? What was that? Sorry.
Sir, how frequently
Yeah.
the frequency of application of these scales, they must be differing across. So any broad approach to that, sir?
I think what we can do is, for example, if patient is an inpatient setting, for example, we can do a baseline and probably we can do weekly. I think
Okay.
that is enough. For example, there is no point doing a HAM-D every day. In contrast, something like a, what is it called? Alcohol, that clinical withdrawal scale, no, for alcohol.
Yes, sir. Yes,
Yeah,
sir.
that has to be done daily. So what scale we are using, based on that, we have to decide how frequently we have to use. But in a outpatient setup, we can do a baseline, and whenever patient is coming to us, and then I was talking about remote one apps, which are actually integrated into the EHRs, where actually patient can do even at home. That is what that is a in thing now. I think in future we are actually getting a lot of submissions related to AI and all that. The most unfortunate part is, unfortunately, none of the team members are mental health professionals. So that is the problem actually. See, once we start, though they are wonderful papers, but the problem is if there is no qualified mental health professional, there's an issue there. So it will come into the domain and then it creates a lot of problem. So I think remote apps have a lot of value. So patient can at home, they can actually tell, okay, they are having recurrence of symptoms. They can monitor their progress. And by the time the psychiatrist or clinical psychologist sees them at follow-up, they can see how the person was doing for past 1 month or so. Yeah.
And so specifically CYR, it's very sir, unique tool. So its
Yeah.
frequency depends upon the scoring also.
Correct. Correct.
Sir, what to do if you have a diagnostic confusion? Do any rating scale have a role in that context, sir?
Diagnostic confusion in the sense?
If we have any, sir, we are not able to make diagnosis still open. We are actually trying to evaluate clinically, and we are stuck. So,
Yeah. Yeah.
do rating
I,
scales
I
have
I
any
think
role?
I think the diagnosis should be based only on ICD and DSM,
Correct. Correct.
and
Yeah. Yeah.
then the scales would be add on there.
Correct. Correct. Shobit, here I remember one person whom I had seen very, very long back, immediately after finishing my postgraduate. This person came to me. His presenting symptom was decreased concentration. So when I did a clinical interview, he was actually fulfilling all the criteria for a depressive disorder. I started him on antidepressants, and okay, patient was fairly doing, but not really good improvement. Then new into the practice, I was also working under Majid Khan sir, like I told. So and I had a lot of fancy with rating scales and all that, inventories and all that. I did a full meaning. I was surprised to see he was actually having ADHD. Then I went back to the history. He had a childhood history of ADHD, which actually progressed into adulthood with a predominant. We know that as the child grows, hyperactivity actually comes down in ADHD and inattention persists. So actually, I was dealing with a case of ADHD, predominant inattention. So this is what, and also he was having a chronic PTSD. So he was fulfilling the PTSD actually is not a chronic cause, but there are few rare cases where people can have a chronic PTSD. He had multiple comorbidities. So I think in such cases, but in principle, diagnosis should not be based on rating scales. It should be through a clinical interview. I think we can supplement it with mini or something, CD or something, CIDI. But the problem is mini actually is not free for use. Okay, for a routine clinical practice we can use, but not for research. And definitely, I'm a big fan of, again, there are a lot of problems there. I think psychiatrists have very negative opinion about psychometry. I'm a huge fan of psychometry. I had I think, Rorschach or a lot of such things can actually throw a light on
So nowadays,
diagnosis.
a lot of people are using these scales for commercial purposes in their
Yes,
clinics. So your take on it regarding permission issues for academic, research, and commercial purposes of these scales, sir?
definitely we should take. I think for commercial, for personal use, for academic, for example, for our outpatient setting, for our clinical practice, there is no need. But when we are using it for research purpose, definitely we should take a permission, because as soon as the paper gets published, the author would know that there is a paper published and they will file a lawsuit. I think we have to be very careful about. It is always better to write a mail to the copyright holders, even doubt. We cannot, even MMSC Falstein scale is not free for use anymore.
Okay. So if many times what people say that there is no reply. You ask for permission, there is no reply,
No, we cannot, sir.
then we should
Yeah.
not use it.
No, we cannot use it, sir. We cannot use it, sir. But the no reply does not mean that we can use it, sir. I
Yeah,
think
yeah,
we
yeah.
have to be very careful.
Sir, a few things regarding MBC, because I think insurance might would be coming in future. So insurance and insurance-based payment. So a few points on this MBC thing.
Yeah, so not much. I think MBC basically means we had to use all these rating scales in our routine clinical practice, and then we had to document it properly in our notes. I think especially those people who are in government service. I don't know how is it in other states, but in our state, Telangana, we have something called Arogyasri from the government, where they want that we had to write notes for our patients daily. So there also, actually, once the patient gets discharged, because we get paid actually, the whole hospital staff get some money out of it, in the sense that there's an amount for that. The hospital gets some money, and then the uh, doctors who are treating the patient from top to bottom also get. So there, all these notes, apart from along with rating scales, are also very important.
So
Yes.
suppose there is a scale, so I want to evaluate whether it is a good scale or a bad scale. So what are the parameters on which I should rate the rating scale, or on which I should evaluate the rating scales?
I think it's basically about the psychometric properties, sir. Mostly the psychometric properties, the reliability, validity, the inter-rater reliability, those are the most important things. And I think, like anything, like, sir, which journal is good? So from India, we'll say Indian Journal of Psychiatry. Same is with rating scales also. So which is the best scale for depression? I think all of us would say HAMD. I think it's a word of mouth, sir, basically. And
Sir,
uh,
your take on whether this rating scale should be addressed at MBBS undergraduate level as a part of competency-based education, sir?
yes, few, not many. I think at least the basic ones like PHQ-9, the MOCA. MOCA is a very wonderful instrument. It is free for cost, at least now. And then something like Cage. Cage. I think these are definitely we should be doing during your undergraduate training.
That is what they mean by rating scales, sir, because suddenly you're out of the graduation, going to post-graduation and bombarded with these concepts which probably they are not very primed of at this UG level,
Yes,
sir.
yes. And I'll tell you, Dr. Shobit, now we are also getting submissions where actually the person is an MBBS student. He just does some study, and then they will use the rating scales which we are using.
Yes.
So that they know more than us actually. Yeah.
I think we have covered all the questions.
Sir, a
Shobit,
comment, yes, sir, a comment by
please
Dr. John,
proceed.
sir. Sir, shall I read it, sir?
Yeah, please.
Sir, your
Please.
presentation is bipartisan and erudite, sir. I saw dictionary. What did the sir means by this?
Which
Sir, there is a comment: the rating scale instruments hide an illusion of objectivity. Just consider SLD evaluation. Scales would be more of means of grants, publications. In short, in a country, in a multidisciplinary setup, many medical models have been diminished to tools for non-clinical exercises. Neurodevelopmental disorders are prime examples. Examples for non-psychiatrist specialists to hide ignorance by quick referrals to non-medical specialists like psychologists to justify artifactual diagnosis. Clinical practice in psychiatry in a country with the numbers is best diagnosed by clinical synthesis.
No, sorry, I did not understand the question. What is that?
Sir, actually,
Just remark.
remark.
Remark. Okay.
So if I just may
Yes, sir.
button, so this thing that we are hiding behind, objectivity behind the rating scales. So rating scales at the end are subjective, like whatever we may say, because if one individual applies it, there will be a different score, and if another individual applies it, so it's a different score. So the subjectivity part is still there. So we can't just validate my diagnosis just by quoting a rating scale, because if you've already made up your mind clinically that this is a diagnosis, you will be seeing the rating scale also in that light. Yes, so that is one thing that I think, that somebody who's already made up his mind and it does not know how the rating scale goes. So, sir, just to put a brief remark, like people from NIMHANS who are not, I've seen many trained clinicians, they are unable to, participate in the certification program. This is because each rating scale has its own definition. For example, PANS's definition for delusion does not include, firm, unshakable belief. It is quite different from the clinical definition of delusions that we have learned.
Yes.
And so we have to use the definition that is given in the rating scale. So that is one mistake many times we make, that we use the definition that we have learned over times and don't use the definition that is there in the rating scale, which is not the definition that we have learned. And so therein lies the mistake. Same is for the hallucinations. So that is one thing that we have to go by the uh, say the manual of the rating scale, see what it says and apply it as it is, so that there is inter-rater reliability. After all, that is what we are aiming for, that if I apply or somebody else applies, we end up with the same score. So if my interpretation of the instruments is different, then it will end up in incoherence.
Correct.
That's it.
Yeah. So even in because you have been part of the so many clinical trials always say that diagnosis has to be based on clinical interview as confirmed with many, and then they want us to rate the use rating scales.
Yes, yes,
Yeah.
yes,
So I
true.
think I think clinical the issue with clinical trials, I don't think that clinical trials are away from reality.
Right,
They are much nearer to reality. They are basically looking at objectivity, repeatability, and
right.
about transparency.
And
Yes,
also the ease of pulling in data from different centers so that they have uniform data, so that that is there.
yes, sir.
At the end of the day, when you're pulling data from different centers, so you
Yes,
do require some uniformity in the assessment so that you
yes,
can pool that data.
yes,
Yeah,
sir.
so someone has asked if someone is starting the OPD, a young psychiatrist. So, what are the rating scales that he or she should keep in mind?
So without any conflicts of interest, I think for mania, YMRS, for depression, HAMD, for if we want to do cognitive assessments, I think MOCA is available in all languages. For alcohol, actually, audit is very good. The problem is it is little detailed. I don't know how
Lengthy,
many of
yes.
lengthy, how many of our patients actually understand. I don't know. For anxiety, HAM-A, I think they're very common. There is no need to use more instruments for one. For example, I have seen like even when papers get submitted to a journal for the same, suppose the disorder in question is depression, they'll be using HAM-D as well as MADRS. There's no point having two scales. But okay, we can have HAM-D with CGI. There's no issue about that. We know that even CGI has bipolar version, like schizophrenia version like that. So I think for each disorder, we can take something which is free. And anyway, because nobody can question us why we have used a clinical a rating scale which is not free. Nobody can come and question us in our practice. So I think one disorder, one scale. For OCD, Y-box, it's a gold standard. For anxiety disorders, HAM-A, simple.
Thank you. Thank you so much, sir.
Yes, I think sir,
Shobit,
there's
yeah.
one question actually. I think there are a few more questions here.
Sir,
Doctor,
please cover.
what are the specific measures to prepare our MD residents and faculty, especially from general medical colleges, to change their attitude to develop quantitative approach towards diagnostic, therapeutic, and outcome assessment? What are your comments on adapting the Western-made rating skills to Indian setting for cross-cultural sensitivity? Yeah, I think this is from Dr. Sai Kumar. I think one thing which I have said in my presentation also, there's a very, very high need for teachers to be aware that it is an in thing and we have to be more cognizant of that. Once we start doing it and once we ask our students to do it, they will do it. That is first part. And about adaptation of Western made rating scales, I think there are a lot of even Indian Journal of Psychiatry, Indian Journal of Psychological Medicine are publishing a lot of scales which are validated for Indian setups. If not, we can do some standardization for India and publish. If not, we can still use scales which are there in other countries, but then we should say that it was not standardized for Indian population. Even for a few of my papers, I had said that this instrument is not validated for Indian population, which was a limitation. And regarding this book, this is not, it's freely available. No need to buy it. It is online actually. It is free of cost.
Yes, sir, I've shared the links.
Yeah. Dr. Shobit has said. Dr. Christina has asked, diagnostic skills employed by inadequately trained assessors for ADHD, ASD, depression can be harmful. Expert clinical reviews. Yeah. What can we do to improve clinical assessment in our country? We employ skills once a diagnosis is made in our setting. I think people should be more accountable. People should be made accountable for what they do. I think that is the only way, and we cannot take it for face value. Dr. Prerna also was talking about the medical colleges and how sometimes we are called to assess a person or medical student or say for an employee from our organization. I think and all that. Mini and serial interview schedules with qualitative outcomes. Correct. Yes. Yeah, MOCA needs training certificate, but it is very, very handy, and I think we can use it. It is not very difficult. It is very, very handy. I think we can.
Yes, sir, but licensing is needed so for only commercial purposes.
I
And
don't think. I don't think MOCA is free as much as I know.
Okay, sir.
As much as I know, Mocha is free and it is available in all languages.
It's in Hindi language also it is available.
Yes, yes, yes.
So we have covered all the questions. I think so.
Yeah. One last issue, sir. Like I was talking about for example, the enhanced neuropsychological battery was there. We wanted to do use for one of our PG thesis. So when we had contacted the developers, they had told very clearly that in your team, a qualified clinical psychologist should be available. I think that is a very important thing because that is what I was talking about competency. Is the person who is doing the assessment competent to do the assessment? I think that is the take home message. So take home message is I think we should not be disillusioned. Unfortunately, in our country, Indian psychiatrists are very much disillusioned with rating skills. I think we need to change our attitude. And with insurance and all that, I think it's going to come very soon to India also. Yes, sir.
Yes, sir. Thank you. Thank you so much, sir. Thank you, sir. I think in the end, we are all in agreement.
Yes.
So, thank you, sir. Thank you so much. Over to chairpersons for their final remarks. Then we go to thanks, formal Thanksgiving. Chairpersons, please.
Sir, I think Sir has made it very clear that we need not be fearful about things being skill-driven psychiatry practice. Rather, we should be prepared for measurement-based, informed, patient-centric care. And yes, it's an essential tool. Overhype is there. Rather than overhype, underuse is there. So we should be ready for judicious use. Thank you so much, sir.
Thank you very much. Yeah.
Thank you,
Those
Dr. Rajshekhar. You like answered all the questions and dealt with it in so detail. Very nice, and I think it seems like we've just scratched the surface of this debate, but it's like you can spend hours talking about this. But I think that it is important that we all talk about these things, and it requires a much larger awareness campaign to educate people who are uh, say not aware of these rating scales and how useful they can be and what their limitations are. Sometimes it is overused and sometimes it is not used at all. So it is both the things, unfortunately. So thank you very much, sir, for enlightening us.
Thank you, sir. Yeah.
Thank you. Thank you. Shobit, can you thank everyone for all of us?
Tufan Pati sir has joined, sir, I think. Sir is there. Tufan Pati sir.
Actually, he's in Lucknow traveling, so
So,
may
so
not
I
be.
think
Yeah.
an excellent session. I think a plenary lecture. I would say a session by Rajshekhar sir, and we actually felt that we were scurrying through our resident days and he motivating us and updating us with every fact with an evidence. My sincere thanks to the chairpersons who have denoted their time, precious time in Thursday evening, and to the very encouraging audience because it's a very specific topic. So I think we can see an handsome 150 around delegates we had for the session. So a lot of people would want to learn this thing, and maybe we can do subsequent sessions on some specific domains for scale assessment as per the book published by Rajshekhar sir. And my sincere thanks to the audience and my fellow colleagues and my senior colleague Alim sir, who is also an co-editor or is a chief editor of a journal. So sir would also fight around with a lot of submissions and having questions around the ratings of it, and to the Torrent Pharma. So I think an excellent session. We learned a lot. Thank you everyone. Thank you.
Thank you.
Thank you, sir. Thank you, Rajshekhar sir,
Thank
Mohan
you so
sir.
much. Thank you very much.
Thank you so much. Thank you.
Bye. Good night, Shobit.
Good night, sir.
Ending the meeting. Ended the meeting, sir. It was wonderful. Thank you so much.